Hi. I would like to thank two previous speakers because they made a good introduction to my topic. I will be talking about new approaches to treatment of personality disorders in childhood and adolescence, the mentalization-based therapies. So they made an introduction and I will skip some parts of my presentation. I will be focusing on the essence of the mentalization-based therapy. I don't know whether you're familiar with that or not. I wasn't very knowledgeable about this therapy 2 years ago. Before this presentation, we used to talk to Gökçe Hanım. These wide spectrum disorders might be skipped in the adult patients, and in the pediatric psychiatry, I believe the contrary. I think the personality development in childhood can be neglected, and this might be related to the time as the pediatric psychiatrists, especially working in the hospitals, we have limited amount of time and it's not possible to make a thorough examination on the patients. And besides that, it is a taboo to say that the child has a personality disorder. In DSM-5, there is a limitation about antisocial personality disorder, which is 18 years old. But as the personality changes in the childhood, we need to be very careful in diagnosing the personality disorders in the children. And this is not discussed much, about personality disorders among the children, and early interventions can be missed. This is my personal opinion, because this is my realm of interest, and I thought about this issue a lot, and afterwards maybe I can work on the neurobiology. Yes, I would like to work with the personality here. Yes, there are dynamic hypotheses, and these hypotheses say that the personality development starts with the childhood. Psychodynamic hypotheses are the sources that we can get the best information about the personality development. And in Turkey, many pediatric psychiatrists, they don't have the therapeutic approach, especially in the state hospitals. For this reason, many children are diagnosed with ADHD, and in the personality pathologies, they do have the attention ADHD, and they benefit from these treatments, but we see that this medication is not solving the source of the problem. How can I work personality disorders at the childhood? And 2 years ago, I coincided with the mentalization-based therapies, and I have been working on this topic, and I tried receiving many trainings about that. Why did I like that much mentalization-based therapies? Because it's something, it is making use of the it's a psychotherapy for borderline personality disorders. Peter Fonagy, he's a psychoanalyst. Anthony Bacon, Peter Fonagy, they prepared this book. There is a center in London, and they're working in cooperation with UCL, and they're doing it as a team. And what they say is that I will be giving you the elements of the therapy, but nothing is new, in this therapy. They are not saying anything different. And he himself also states that during his presentations. I took the theoretical part of that training, and those coming to those trainings, and also in the books they say that we don't say anything new, only the existing concepts are interpreted with a different approach, so you will be thinking similarly while you're listening to my presentation. Along with the definition of the mentalization, and what do we do in the therapy? Because the mentalization-based therapies, it is a lean therapy, you know. And mentalization-based therapy is quite simple, and they summarize the mentalization and attachment. And while defining the mentalization, Fonnelly makes that definition is that our and others' behaviors is interpreted under the light of the desires, needs, emotions, beliefs, and explanations. Therefore, there is the mind behind that, the ability to understand it. I have the mind, and the other person has the mind, because mind is not something visible. And we have the abstract skills to interpret the skills of the mind, and this can be different in different people. According to Fonagy and the Bateman, this skill can be problematic and cannot be functioning well. Therefore, personality disorders appear. And he focused on the definition of the borderline personality disorder, and then it was expanded to other personality disorders afterwards. Attachment, you know, mentalization develops with the attachment, and also many items, many terms are being used. The child discovers his mind in the mind of his mommy. As you can see in the picture, the mommy talks to the baby, because the baby doesn't have any opinion, any idea about the emotions in his mind, and the mommy tells him for the first time, "Oh, are you happy? Are you relieved?" The mom talks to the baby, and the baby, in the eye of the mom, sees himself as a person with results. And the child sees his own mind in the eye of his mother. And this is a special thing, to see your mind in someone else's mind. The emotions, the intentions are there. This is understood by the child. And marked mirroring. What is it? When the baby sees himself in the mind of the mother, it's called as mirroring, you know. "Oh, are you hurt?" for example, the mom says. It's called as the mirroring. And when we say marked mirroring, it's a little bit different. As you can see here in the picture, the baby is hurt and he's screaming and crying, and the mother doesn't give the same reaction. The mother is sad, but she sees the emotion of the baby, but she's calmer. So this is the marked mirroring. It means that, you know, I understand your emotion, but this is not something to be panicked. Therefore, the emotional regulation is being learned during the relations with the mom in the babyhood. And along with the mommy, the child, as he is mirrored and as he learns the regulation, emotional regulation, attachment happens. And attachment is a neurobiological phenomena. And you can think what Murat Bey told you about them, because when you receive an article, in the entrance you can see the neurobiological explanations. And attachment is a neurobiological phenomena, and along with the mentalization at the brain related to the attachment and the safe attachment, secure attachment, the emotional regulation can be achieved. Sufficient motherhood. At the beginning, baby is hungry and the mother feeds him. You know, symbiosis, or it's veiled in the other hypothesis as well. And the brain says that my mind and my mother's mind, they are the same. But after a certain amount of time, the mother fails to understand the feelings of the baby, and in a healthy relation, either, out of 3 needs of the baby, for 1 need, the baby is disappointed, and the baby understands that my mother's brain is different. She can sometimes understand me, but if she is there twice out of 3 times, yes, she's someone else, but she's mostly next to me, so I can trust her. This is the approach. And the empty feeling in the borderline personality pathology, Winkett says that if the mother, let's say that a person in the emotional regulation, the most relieving part, if we feel bad or if we have challenging times, the most relieving thing is to have relation with our attachment object. So if I'm mirrored, this is something we do during the therapy, understand the patient, this is something very relieving. But there are different psychopathologies about that, and the mother misunderstands the child, and let's imagine that the mother has borderline and the mother is quite aggressive and she can't have the emotional regulation. Let's say that the child spills something, then the mother says that you are mischievous and you did it on purpose, and the child says that this is not something acceptable, and it is alien self, and that emptiness feeling is happening. Mentalization. When we look at that, it changes developmentally. I'm going to make definition of 3 thinking way. Theological position. It's the expectations about the behavior, and it's related to the physical objects, and when there is a problem with the mentalization, it's called as the pre-mentalization, and this approach can appear. Okay, the first one, teleologic position. The spoon, for example, if he pushes it, it comes back. So the baby focuses on the physical world. And this might happen in the adulthood. In the borderline patient, for example, they would like to see a concrete proof. In order for me to understand that he loves me, he needs to send me a message, or he needs to buy me a present. Only the concrete things can be shown, only the emotions and the needs can be understood. It's understood at the teleologic position. At the age of 2, they pass it and they start understanding the minds, and around 3 to 4 years old, the child starts to understand that the mind of the mother is different, and this is an important step. The minds are different. My mind is different. My mother's mind is different. My mother can think differently. It is the mature approach. And other two opinion, psychic equivalence and pretend mode. In the psychic equivalence, the child presumes that whatever he thinks is the reality. He can't discriminate between the fantasy and the reality. And the pretend mode among the adults, when my boyfriend doesn't send me a message, let's say that, oh, he's cheating on me, and that idea is being lived as if it is real, and in the pretend mode as if it is a game, as a fantasy. The cognition and the emotion are not connected.
During the fight you're doing this and you're saying consecutive things, and it's when people are in pretend mode, and between the thoughts and emotions the connection is gone. These three thinking ways actually are the intervention points in mentalization. I'm going to explain this in these sessions. It is actually it's a very plain therapy method. Another, there is epistemic trust concept, and here if the bonding is say healthy and safe, if the child believes that the mother is sincere, and then he thinks that the people he confronts are sincere. If there is a problem in bonding, people do not trust, and in the personal people with disorder, people personalities, when they don't get the call they expect, they say that he doesn't love me. Of course, the mentalization have many dimensions. One is the automatic and controlled. Prefrontal cortex is involved with the rational thoughts. The automatic mentalization is sudden and for instant, and with the stress reaction it affects when the limbic system is more involved, and there is a self and other. You know, the understanding of oneself, mentalization might be deteriorated, or understanding the other could be deteriorated, and there's affective and cognitive mentalization. I'm going to show you a table. These could be different in all the personality disorders. In one, this personality disorder, affective can be deteriorated, and it depends on the table. And there's internal and external mentalization. When we say external, there is the external cues. For example, a borderline individual, it pays attention to facial expressions and tries to understand the motivation and the emotional status of the person, or the mental state of the person. And for example, there is, let's say that he is waited in the polyclinic line. It is, let's say, a very crowded polyclinic. When he is in with the therapist, when the therapist is sulking, the borderline personality thinks that now he's sulking, and then does not want to attach importance to me, and he doesn't love me. If he uses the internal clues, the polyclinic, he will think that the polyclinic is a very crowded, and maybe outside my sulking not because of me, because the person cannot use the internal mentalization, is not able to say this. Of course, I would like to show you this as well. It's about, we said controlled and automatic mentalization. There is such a graphic. As you can see in the graphic, there is a peak point. As you can, there's a key point. As you can see, people in in a certain level of stress, they make a controlled mentalization. If the stress level increases, they're going to fight or run away. So then goes into automatic mentalization. This is for survival. And for biological and evolutionary, there is such an explanation. Actually, if we have the potential to lose mentalization when we are very angry, when we are very sad, when we are under the influence of very intensive feelings, we can go below the threshold and lose the mentalization. For the people with personality disorder and borderline patients, the threshold is very low. So in small frustrations of daily life, they can go beyond this threshold. As you can see here, you see a narcissistic personality disorder, and you can see a borderline personality disorder. For example, in borderline, there is external mentalization is not very strong. However, there is in borderline external clues are focused, and there's an extremism on this. Sometimes the hypermentalization can be harmful as well. And it means attaching two mentals to someone. It's a reason of pathology. You say affective. In borderline, affective mentalization is very high. In narcissistic personalities, affective is very low. Cognitive mentalization is more intense. And based on the bonding strategy and pattern effects in therapy, what is done is the following. When they see the deterioration in mentalization, they intervene. Therapy trainings are very short, for family therapy 4 days, and for adolescent therapy 3 days. And more than half of the trainings is role plays and videos. And when you see with deterioration mentalization, you go to start and you try to understand the patient's emotions, and there are some distinctions between the psychoanalytic results. Therapist is there, therapist is actively there. However, the therapist should be humble and should not make interpretations like an analyst. In mentalization-focused therapies, it is not appropriate to make interpretations. The role of the therapist is to be curious about the mentalization of the mental state of the patient, and also there is a modeling by the therapist by being curious about the person, because there is mentalization or either mentalization or hypermentalization, because the patients, they think that they understand the mental state of the people. The therapist actually set an example. We always say that the mental is opaque and we cannot see the mental. However, if we can ask open questions, we can only see. And the therapist, everybody can have mentalization problems. The therapist should control their processes. And if there is a problem in deterioration in their mentalization, the patient can take the responsibility of this. And with the presence, the therapist should be there with their presence, because the therapist is a factor of bonding. The therapist should be there with the tools in a sincere way. There is the practice of this in personality disorders. There is an individual session in a week and a group session in adolescent 1 week, and for family therapy 10 to 12 sessions. And for child, it is like a game therapy. This is a good book. I'd like to recommend this book to you, written by a whole Danish group. And you can see the practice area. There is the interventions of the parents. The studies show that in risky parents, the reflective parenting the fact that the parents can mirror the child, even if they have the bonding problems, if they make reflecting parenting, there is no problem in the child. So in risky parents, in adopted child, in disadvantaged groups, in personality disorder parents, there are some programs. And regarding the evaluation methods, there are too many methods. The list actually is I'll go through all of the methods. I'm going to participate this. They're generally 3 or 4 days modules for each. I made the models, so there are many different models for evaluation. Thank you.